From beautiful Sydney, the city of Opera House, Darling Harbour, Blue Mountains, and beautiful beaches, this is ICU Primary Prepcast, a monthly podcast about physiology and pharmacology in intensive care.
Welcome to ICU Primary Prepcast. Hi, my name is Swapnil. I work as intensive care specialist in Sydney. And today I'm joined by our new celebrity of the podcast world, Mike Clifford from Melbourne. Welcome, Mike.
Thank you, Swapnil.
Your last podcast was quite a big hit. I received a lot of positive feedback from a lot of candidates saying thank you. In last podcast, Mike shared his insights as an examiner, how to prepare for primary exams and also how he goes about setting up questions for written paper or vivas. Today's episode, we are going to do quite a unique thing, which is more of a meta-thinking process. Now, meta-thinking is thinking about thinking. So what we're going to do is we are going to dive deeper into Mike's brain and see how he designs his Viva and experience that in the real time. So Mike has helped us walk through the examination process. And this time he has kindly volunteered to share some of the Vivas that he has written for the primary exams. So first of all, we'll go through the Viva. I will be the candidate answering Mike's tough questions, and I'll try my best to answer them as much as I can. And then I will get Mike to talk through about the process of writing this Viva. So over to you, Mike.
Okay, good. So thanks, Swapnil. So we'll start off with this Viva, which is one that I've used both for practice for candidates and a very similar structure for the exam. This is the level that you can expect to get on the day. You'll find that some of the areas are quite advanced and we wouldn't necessarily expect the candidate to know all of the information. It's important to remember that. So you don't have to know everything past the Viva. So the Viva is designed to both provide good opportunity for a good candidate to pass and also good opportunity for a very, very good candidate to score very highly. So the first thing to remember is that when you walk up to the Viva on the day, on the wall outside the room, there is a little stem which has been carefully designed to let the candidate know what they're in for so they can take a deep breath and have a bit of a think around the topic. There's 2 minutes between Vivas, so that's a long time, 2 minutes, but it actually gives 2 minutes for the examiners to mark the Viva that they've just done, and it also gives plenty of time for the candidate to move between rooms, to regroup, and also to potentially plan what they think their answer might be. So today's Viva, the stem on the outside of the door actually says this. So it says, this Viva will explore the pharmacology of anticholinergics and Propofol. What drugs are you aware of that act directly on cholinergic receptors? So that's the stem. And then Swapnil would come into the room and then I would ask him, so Swapnil, you've read the question on the outside. You understand the question?
Yes.
Okay, good. So why don't we start off by telling me what drugs are you aware of that act directly on cholinergic receptors?
So there are two types of receptors. One is nicotinic receptors and the second is the muscarinic receptors. So in nicotinic receptors, there are agonists and antagonists. So agonist examples are nicotine itself and succinylcholine, while the antagonists which act at nicotinic receptors are neuromuscular blocking agents. While muscarinic receptor, again, the drugs acting at receptors are agonist and antagonist, and example agonists are muscarine or pilocarpine, while the antagonists are commonly used are atropine, glycopyrrolate, ipratropium, tiotropium, and some of the antiemetics.
Okay, good. You've mentioned atropine. What is atropine?
So atropine is tertiary ammonium alkaloid ester of tropic acid.
Okay. Can you tell me something about the pharmacokinetics?
So pharmacokinetics is about absorption, distribution, metabolism, and excretion. So basically, as I mentioned before, so atropine is a muscarinic antagonist. It's directly acting and it's a reversible. In terms of its routes of administration, it can be given orally, intramuscularly, intravenously, or subcut. It has got a high oral bioavailability. In terms of distribution, I don't know exact volume of distribution, but it's widely distributed. And usually it acts in central nervous system and peak is usually in half an hour to 1 hour's time. Its overall elimination half-life time, it's like basically around 2 hours. And it gets metabolized in the liver, 50% hydrolyzed and 50%.
That's good. So how does it differ from glycopyrrolate?
So glycopyrrolate is quaternary amine, while the atropine is a tertiary amine. Glycopyrrolate has got a poor oral absorption, and compared to atropine, it has got a less CNS penetration.
Okay, good. So if I were to give you 40 mics per kilo of atropine, what would happen to you?
So in terms of its effects on different system, like pharmacodynamics, in short, cardiovascular, it will have significant chronotropy, so it will cause tachycardia. Mild inotropies via muscarinic receptor, so it will have some contractility, but obviously it won't change much in the blood pressure. In terms of the respiratory system, it will cause bronchodilation via muscarinic receptor M3, and it will decrease this bronchial secretion, so it will dry the mucosa. Similarly, in GIT, it will cause decreased salivation, decreased acid secretion, and it will basically prolonged gastric emptying. In terms of central nervous system, it might cause atropine fever and also can lead to confusion or delirium. In terms of ocular side effects, it can cause mydriasis, so pupillary dilatation. The other effect on the urinary system is can cause urinary retention.
Okay. Why do we avoid doses below 10 mics per kilo?
Because atropine has got a potential to produce a paradoxical kind of bradycardia, and mainly due to kind of central inhibition of presynaptic vagal fibers.
Oh, very good. Is there any particular age groups that are more at risk of that?
Mainly elderly.
Okay, good. Can you explain what is meant by the term antagonist?
So antagonist is the substance which binds to a receptor and blocks the response to endogenous agonist without inducing its own downstream effect.
Okay. So how does an antagonist differ from an inverse agonist?
Antagonist may become an inverse agonist when the receptor exhibits a basal constitutive activity, and the inverse agonist blocks the receptor, preventing the binding of endogenous agonist and by also inhibiting the basal receptor activity. So it kind of inhibits the downstream effect, and atropine is an example of that.
Yeah, good. Excellent. Okay. So we might move on now and talk a little bit about Propofol. Can you tell me what is Propofol used for?
So the use of Propofol can be, again, multimodal use. So it can be used as a sedative in ICU patients. It can be used as an induction agent for intubation. It has got its anti-convulsant properties, so it can be used in the treatment of seizures. Also, it has got anxiolytic property, and it can be sometimes used as antiemetic. But
okay. Where does Propofol act in the central nervous system?
There's no specific location as such, and it probably acts at cortical level and spinal level, but there's no specific location.
Okay. Do you know of any areas that it might act in terms of which parts of the cortex?
No.
Okay, that's fine. So what receptors are important for that activity of Propofol?
So mainly acts via inhibiting the transmitters like excitatory neurotransmitters such as glycine and GABA, and thus it basically reduces the sodium channel opening time. Mm-hmm. It has also got some activity on NMDA channel, and it inhibits the NMDA channel and thus modulates the sodium getting. Mm-hmm. And it also reduces some acetylcholine release in prefrontal cortex.
Okay. Any other receptors that have been recently described?
Probably on the cardiovascular side, alpha-2 receptors.
Okay. So why do we use it in intensive care?
So the pharmacokinetic properties are quite favorable to ICU. First of all, it has got its rapid onset and offset. Even we use Propofol as an infusion, it has got a favorable kinetics because it gets cleared from the system quickly. It is quite stable in terms of when it's exposed to environment. So even in the syringes, it remains stable for several hours. And there are no kind of major active metabolites that hang into body. So even in patients with renal failure or hepatic failure, it's kind of safe. And it has got a partial organ independent metabolism.
Okay. So what are the contents of a Propofol ampule?
So Propofol comes as an emulsion, usually available in strengths of 1% or 2%. The main constituents are soybean oil. The other is egg yolk or egg phosphatide. Then glycerol, sodium hydroxide, which is mainly added to kind of neutralize or balance its pH. And then it has got another preservative, which is the sodium metabisulfite.
So what's the egg for?
The egg is basically used as a stability of the emulsion.
Okay. So how many calories are there in the Propofol?
So 1 meal is equal to kind of 0.1 gram of the fat, which equal to 1.1 kilocalorie.
Okay. All right. So is that an important amount of lipid?
Yes. So that can be significant. So if you run as an infusion, you might be end up in giving a lot of calories.
Okay. All right. So how does propofol accumulate in patients?
So the terminology is important to understand. Is context sensitive half-life.
Okay. So what's that?
So basically, this is the amount of time required for a blood concentration to decrease by 50% after maintaining a constant concentration for various duration.
Right. Okay. Do you know of any other drugs that have context sensitive half times that are important for intensive care?
Fentanyl.
Mm-hmm. What happens to fentanyl?
So it has got a prolonged context sensitive half-life.
Okay. We'll stop you there. That's good. Okay. That's very good, Swapnil. So for the people that are listening, a couple of things to note. One is that was a a pretty good performance, which we would expect from an examiner. And if Swapnil was a candidate, he would have scored very highly. And rather than going into the detail of how he actually scored, we can talk a little bit about the structure of the Viva. So most of our Vivas we prepare in two halves, and they're two halves that make sense around the syllabus. We can often pick a physiological component that will lead into monitoring, or we might pick physiology and pharmacology, or we might pick pharmacology and an aspect of pharmacology that leads on to something else, or sometimes we'll just group two drugs together like this one. So we started out looking at antagonism based around the anticholinergic system, and then we've moved into propofol, some of the detail of the pharmacology there.
Thanks, Mike. Thanks for sharing this, Viva, because this is really important and interesting. That's why I really like to pick up your brain here. So even you chose two drugs, you didn't just go like a traditional way of asking the question about drugs like pharmacokinetics, pharmacodynamics, and side effects. Within the Viva of atropine especially, you moved quite a bit from different topics. So can you just walk us through your thought process when you constructed this Viva?
Okay. The concept was to start out looking at receptors overall. And then because we like to have a question for the candidate that's what we call a gentle hello, right? It's like a shaking of the hand. So asking someone about receptors should be relatively straightforward. And we don't necessarily get into too much detail. If they can actually get into detail very quickly, they might score more marks. But we just want an answer. In the same way that the first propofol question was, what is it used for in ICU? There's nothing hard about that question. They're just calm down, take a moment, answer the question. And then we start going a little bit deeper. We were expecting him to say atropine, and obviously he did. And if he didn't say atropine, we would ask him anyway. And obviously the time it takes to get atropine out of a candidate is time where marks are accumulating or not accumulating. So once he said atropine, we can then move into the second phase, which is, okay, well, tell me about atropine. What is special about atropine? How do you give it? Because it's a commonly used drug in both anesthesia and intensive care. And as soon as someone gets a bradycardia, if they're not arresting, you can whip out the atropine and you give it, but you don't think about what dose you're giving. You'll give an ampule, that might be too much. Suddenly you've got tachycardia you've got to deal with. So it's about just teasing into, well, okay, you've got that, you've got an anticipated effect of the drug, and now you've got a side effect of the drug, which is too much of that effect, the tachycardia. How long are you going to expect that to last for? What are you going to do about it? So spending a little bit of time on how do we give the drug, what's its bioavailability, what's its half-life, how long will it take to have an effect, and then a little bit of time spent, well, what happens if you give a smaller dose? We can go, we'll spend some time going into all of the effects of a proper dose, and we can just go through the systems, and we'd expect a candidate to have read what's the cholinergic nervous system, what's the parasympathetic nervous system, so therefore if I block it, what do I get? So you can almost do it from first principles, but to know some of the details of, well, atropine gives you mainly chronotropy without inotropy. You can get a tiny little bit of inotropy, but most of the effect is on heart rate, not blood pressure, and that's good. But there's also effects on the respiratory system with bronchodilation. There's gastrointestinal effects, there's effects on the renal system, on the ocular system, which might be important if they've got glaucoma. So you just open up an enormous opportunity for candidates to answer that question. Now, we've allocated several marks to that bit, so we can spend some time staying and playing there. And if their knowledge isn't as strong as Swapnil's and they don't just blurt it out like they've got information pouring out of them, we can spend some time just asking them, well, what about the renal system? What about anything that might happen with the eyes? And that slows it down. It's no more confronting, and we often get the same information out of the candidate, but because it takes a little longer, they're using time and they're not scoring as highly. But that's okay, because we know we're going to get that information out of them. They're still going to pass that V. It's highly likely they'll know that information. Now, the better candidate, we've got a deep question. We'll go, well, what happens if you give too little a dose? Does that matter? And it does in this particular drug because you can get a sort of quasi-paradoxical response because you get early central release and you get a vagal phenomenon. So you can actually get a paradoxical lowering of the heart rate with atropine. And it's an unusual response, but you often see it, and you often see it in babies. So we often overdose babies. We never give less than sort of 100 mics to a baby. And that's because we don't want them to be bradycardic. We're giving it for the other reason. And then we've got, depending on how long it's taken us to that point, we might have a couple of questions at the end that we can just spend a little bit of time on or a long bit of time. And that's where what's meant by the term antagonist, what's an inverse agonist, that's quite detailed pharmacology. And for someone to be able to explain what an inverse agonist and why atropine is considered that, you've got to have a deep understanding and you've got to have read about that. Now, not a lot of candidates will have gone into that depth, and that's okay because that's not a pass-fail part of the Viva. That's deep knowledge. Let's spend the last little moment with this examiner there and see what they know. And if we run out of time, we run out of time. And then you can see there's sort of a sudden field change in the Viva, and we go over to Propofol. That's going to be the second examiner. There's a bit of a time for taking a moment and regrouping, and you've got a migraine because you've been asked about an inverse agonist and you can't remember a thing about it, and you feel like you're going terribly. But then here's a chance to regroup. Here's just another gentle question. So it's okay. Now we're going to reset. Let's just talk about Propofol and how we use that in ICU. So that's how the atropine component of that Viva was structured and how we thought about it.
Thanks, Mike. So what you highlighted there for candidates, there are a couple of important things for me. So first of all, there are two halves of the Viva. So even if you go terribly in the first half, there is a chance to pass the whole Viva because you can still do much better in the second half. So don't get disappointed if you can't answer one or two questions in the first half. Always make sure that you still go through the whole Viva and try to answer questions as much you can whenever you get a chance. The second important thing is if you can't really answer any particular question, just tell examiner, I don't think of any answer here. Let's move on because there might be next question that you might know better and you get marks for that question. So don't really spend a lot of time. The other important thing that you mentioned about Mike is examiner know which questions given more weightage to. So they will try to keep you in that question or answer a bit longer because they're looking for more substance there and because that question carries more weightage. If they really want to move you forward, they will say so and they will say, that's enough. Let's move on to the next question. So what I was trying to illustrate here is try to read the body language or the clues from the examiner because examiners, they will try to help you as much as possible to move through both Vivas and get you the maximum mark as possible.
Yeah, that's very good, Swapnil. And some questions seem easier than others, and some questions don't have good answers. So, for example, where does Propofol act in the central nervous system? Despite the fact we think we know that, that's actually very difficult to describe. So there's not a lot of time spent on that question. It's just does the candidate understand that in fact it's all through the brain and the spinal cord and that it's binding to lots of different receptors. Now the money's in which receptors, and the more you read, the more you realize Propofol binds to lots of different receptors, and increasingly we're finding more and more activity related to where Propofol is. I mean, we all understand that the predominant effect of most of our drugs are through the GABA receptor, our sedatives, and Propofol is predominantly that acts on the GABA receptor, but Propofol does act on lots of other receptors, and that's one of the reasons why it's different when you use Propofol or thio or benzodiazepines. You get sedation, yes, but you get a whole lot of other effects that are not quite the same, and that's because the drugs aren't as pure as we would like them to be. So exploring that for a little while, but not a long time. When you think about what it's used for, that's actually a very easy question for a candidate. There's lots of things we use it for, but if you just stop for a moment and think, well, when have I used it in ICU and what did I use it for? Well, we use it on almost every patient every day for sedation. That's fine. But I do remember using a whole lot more of it on a patient with epilepsy. And I can remember one of my consultants wondering about being a bit concerned about using high doses. And I remember something vague about a metabolic problem there. Maybe it was fat, I don't really remember. But then all of a sudden I'm being asked what's in the ampule. And one of the problems with ICU is that we don't often draw up our drugs. But Propofol, you can see beside the bedside, it's this white stuff, doesn't look like anything else except intralipid. So there's something really special about it. And the fact that it's a milky substance means we want you to understand why that is. It's a drug you're using every day. It's quite special, and its pharmacoceutics are really interesting, and you should know about them. And they have impacts on patients. They have impacts on drug delivery. They have impacts on risks of infection. So there's lots of stuff about Propofol. Now, we don't expect every candidate to be able to just rattle off the 8 ingredients the way Swapnil did. That this is what we expect from an examiner. But, being able to talk about each of those individual components for this particular drug is important. Now, lots of drugs have excipients in them that we don't ask about because they're not important. But some drugs have important excipients, so we do, and we spend a bit of time talking about it. And that's why there's quite a bit of marks in that section allocated. And if you didn't know what's in Propofol, well, that's okay. We might say, well, what does it come in? What's the white stuff? There's water, obviously. Why do you think it is white stuff? And then we'll jog your memory. And then if you can't think of anything, that's fine. We'll leave that and we'll move on. We're not going to stay there and spend a whole lot of time. And the quicker you say, look, I really don't know what's in Propofol, we might say, well, okay, that's fine. We'll move on. Okay. And similarly, how many calories? Well, if you don't remember that it's actually just 10% intralipid, well, there's no point staying there. We can tell you, well, if I told you that it was intralipid 10%, does that help? And if it doesn't, well, it doesn't. We move on. And then we're into context-sensitive halftime, which is another huge area. But again, we're at the end of the Viva, so we're not going to be able to spend a long time there. It's more to glean an appreciation of one of the beauties of Propofol is this function of context-sensitive halftime and the fact that it doesn't tend to accumulate and that because it has, extrahepatic metabolism. So it's a lovely drug to give for a long time, and then you turn it off and the patient will still wake up. And then we can talk about, well, what drugs do we use that don't behave like that? And really, by then, we've run out of time. Very few candidates are going to get any further than that. And in fact, we've run out of questions. So if we've got to the very end of that Viva, and let's say we've had some big gaps because the candidate couldn't remember certain things and we've got to the end of the Viva, well, we might then take an opportunity to go back and see if we can get you some more marks. So we might say to you, okay, we talked about Propofol in the ampule and you didn't know what was in the ampule. If I told you that it was actually there was soy oil and water, how do we keep the soy oil from separating in the fluid? What might we use to do that? And that might take us into a discussion. And if there's no answer there, we might say, okay, well, have you ever made mayonnaise? But, how we do that at that time to fill in time, we're just trying to be gentle with the candidate. We don't want you leaving the room thinking, well, that was awful. And even though you're not necessarily scoring any marks for that last 30 seconds or a minute, we probably will have got enough out of you to guarantee a pass for the Viva. And if you haven't passed one half section, it really doesn't matter. As you said, Swapnil, you may well have passed one half and you may have got slightly less than half in one half. So that Viva, you may still pass that Viva overall, or even if you don't, you'll walk into the next Viva and you're highly likely to pass that Viva. So you have to be relatively reassured, as we said last week, that by the time you get to the Viva section of this exam, you are very likely to pass. And the Viva is our opportunity to explore how very much you know about certain areas or how far we can delve into some of the detail just to see what you know. And there will always be parts of the Vivas that you do on the day where you will go, I don't know. I haven't read that. I've never even heard of that. I have no idea what you're talking about. Why is there egg in Propofol? Absolutely no idea. That doesn't matter. You're not being passed or failed on being able to answer every single question. This is our opportunity to just explore and explore.
That's absolutely right, Mike. And I just said, refer back to previous podcast where you mentioned that Propofol is such a commonly used drug in ICU that every almost single patient who is intubated will probably be on Propofol infusion. So when you look at the ampules which are hanging or been used at the bedside, sometimes just read the content which is written on the ampule, and that helps you to just revise your stuff. And I think that's probably the best way to prepare the drugs or what are the contents in those ampules and other things. And the other important point that you said at the beginning of this podcast is you can really branch from anywhere into Propofol or anywhere from Propofol. So we might start with Propofol and then go into, say, how do you manage the ICP, and then just understand the examiner psyche in terms of how they go about conducting the Viva. So that's the end of today's podcast, folks. Thanks, Mike, for your valuable time and sharing your Vivas with us. Now we're coming to the end of our podcast, and I can see your eyes are lighting up and looks like you got some joke for me.
Yes, as always, more time was spent searching for an appropriate piece of joke for you. And, I do this in memory of Maddie, who I know is out there studying for her second part exam. So I'm sending her some good wishes. But I've got one for you, and it's, why should you never lie to your ICU radiographer?
Oh my gosh. My situation actually worse. Nobody sympathizes with me because they will refuse x-rays.
No, Swapnil, because they can see right through you.
Oh my gosh. Actually, I chose the worst partner, to be honest, Mike. After Maddie, you are getting even tougher for me.
My jokes may not be as good as Maddie's, but there's no less time being spent put into finding them, let me tell you.
No, you're doing a great job on that front, Mike. So thanks again, folks. We'll be back in fortnight's time. Till then, bye.
See you later.